I think most of you are probably too young to remember the movie that is being referenced there, but yeah, The Exorcist. Yeah, you. In retrospect, now today, it's not as scary as it was at the time. Maybe I'm just younger. I don't know. All right, so we're going to go ahead and talk about using graphical patterns to identify settings, to make changes, and we're going to break the breath up into the 4 phases. I think Lori covered some of this. We're going to start off with looking at the first transition from exhalation to inspiration. Talk about auto PEEP and how we identify it. Patient who was having problems with triggering or where there were auto triggering, how would I be able to identify that on a graphic? What would cause the process for correcting a failure to trigger or the auto trigger, how we're going to do it. But again, we're going to start off with 1A here being the change from exhalation to inspiration. So you look at a ventilator screen, especially this happens to be the Draeger, and you can see you have just a ton of information available to you. What the hell does it mean? Where do I start? And we start at the beginning. So here's what we're going to do. Take a look after these slides. There's a graphing assignment. It's called graphing assignment number 1, and there should be some paper that is there, some graph paper. I want you to go ahead, take the graph paper out, get a pencil. I recommend a pencil. And we're going to draw 2 complete breaths for each of those settings, 1 on each side. On one side will be a volume-based breath, and you have the settings there. You have the settings. So do case 1 on one side, do case 2 on the other side. One's a volume-based breath, one's a pressure-based breath. What will the pressure, flow, and volume tracings look like? All right, so we talk about the ABCs of breath delivery, kind of like this approach, because we can identify various points in time where there might be something going on. And this is basically a pressure-based breath, but you can do the same thing for a volume-based breath. There's A, which is the trigger, conversion from exhalation to inspiration, and I'm sure that Lori covered that pretty extensively over the summer. I then have my inspiratory phase. I have a plateau phase. I have an end of inspiration and the beginning of expiration, and then I have my baseline. And all 4 components of that we'll spend a little bit of time talking about. So we know there's multiple ways to go ahead and trigger it. We'll talk about them as we go through. First of all, machine trigger. Machine trigger is pretty easy. I note that there's not a patient trigger present. There's no alteration in the, usually we identify it from the pressure tracing. There's no patient effort. The rate has lapsed so that now I end up having a breath delivered. My set rate is 20. Every 3 seconds I'm going to see a breath initiated. In this case, the one on the left, there's no patient effort. It's a machine-triggered breath. The one on the right, you end up having a patient trigger present, and that's also denoting the patient being on 5 of PEEP, the distance of the baseline there. The patient trigger is controlled by the sensitivity settings, and the 2 that we covered over the summer were flow and pressure, but there are some other ones that are there that we need to talk about now. Conventional ventilation, we're going to go ahead with a 1 to 3 liters per minute for flow, -1 to -2 for a pressure. So if you say 2, you're in the ballpark for both. We know how flow triggering works. I have a delivered flow and a return flow. It's going in a circle. If I have my flow triggering at 3 liters per minute, Once 3 liters per minute is depleted by the patient, it triggers the breath on so that the delivered flow is no longer equal to the returned flow. Patient must be taking some of it, ventilator triggers on. And by the way, the most ventilators do not allow you to adjust whatever base flow there is, whatever bias flow is going through the circuitry. What they do allow you to adjust is to what extent that has to be depleted before the ventilator triggers on. If there's PEEP applied and you got a leak, it's going to trick the ventilator. And the ventilator is going to think that the patient is wanting some air or is wanting a breath because it's not seeing all that volume or flow come back to it. So what we need to do is either adjust the base flow to maintain the PEEP, which in many cases you can't control, increase the sensitivity, or look to going to a pressure triggering mode. I actually had a hospital, the neurologist came in to, the patient was suspected of being brain dead, and the respiratory rate was set at 12, but the patient was doing 20. And he said, well, that's impossible. If they're brain dead, they can't be triggering more. And the patient had a leak. They had flow triggering turned on, had some PEEP on. And the reason why the PEEP is an important component of that is how does the ventilator maintain PEEP? It maintains it by applying some pressure against the exhalation valve, right? And in the face of a leak, that flow is allowed to circulate throughout the leak, and the ventilator triggers itself on. So that was the problem that they had. All they did then was a switch to pressure triggering, and the triggering by the patient went away. So here I have a leak. How do I know I have a leak? My volume isn't coming back to baseline. I have the PEEP level dropping down to the point where it's triggering the ventilator back on again. And that's called auto-triggering. And again, it happens more often when we have PEEP. Right. Because it promotes the, or it exacerbates the leak. Give me a second here, guys. Okay. What about pressure triggering? Well, pressure triggering is just looking for a drop in airway pressure. When that airway pressure decreases to at the sensitivity level, flow begins. And it too is affected by leaks with PEEP, but not as profoundly. So here I have 5 centimeters of PEEP being applied. Notice that it's requiring them to draw back 5 centimeters of water to trigger the breath on. And basically we need to adjust the sensitivity setting. That's a lot of work on the part of the patient.
What I've noticed in the hospital is like 5 is like standard.
5 of PEEP?
Yeah.
Yeah.
So usually we want between 1 and 2 though?
PEEP?
Oh no, never mind.
You want pressure triggering, sensitivity. Okay. And the same idea. If you have a large enough leak, when you have PEEP present, that leak will auto-trigger inspiration, and you can try to adjust the sensitivity. But in many cases, you just have to find the source of the leak. So here I know I have a leak because my volume isn't coming back to baseline on either the flow volume or the pressure volume loop. Fix the leak, volumes all come back to where they should be. And if that isn't really clear right now, that's okay, because we'll cover loops a little bit more in depth in a bit. circuit leak, auto trigger. And we talked about that before too. Some ventilators are not PEEP compensated, meaning when I say I have a 2 centimeter of water trigger, that 2 is referenced to the PEEP level. If I start at 5 and I want to trigger at 2 centimeters of water, when it drops down to 3, it triggers on. That's not true of all ventilators, especially when you start talking about home ventilators and transport ventilators. Some of them are not PEEP compensated. So you have to adjust your sensitivity appropriately. So if I have 6 of PEEP present and I want to have -2, they would need to draw back -8. So I really should change my setting to something higher. Does that make sense?
Yeah. How do you draw that out?
Pardon me?
I can look at it, but no, it doesn't make sense looking at it.
Well, what I would end up doing is changing this to something like, if I'm on 6 of PEEP, I want to change this to 4. Change my sensitivity to +4.
You change your sensitivity to +4.
So that
You're
it's
on a PEEP of 6.
and you're on a PEEP of 6, so it would be a pressure change of 2. And like I say, you see this a lot on transport and home ventilators, because they don't know how much PEEP they're on. Because the PEEP in many cases is external. It's not something that's set by the machine itself, using a PEEP valve. So again, pressure may be the backup. And when we got a PEEP and there's a leak that's uncontrollable, flow will not work, you can go ahead and try doing pressure triggering to prevent that auto triggering from happening. Let me defer this slide to a later date, because it's basically talking about flow, pressure volume loops, and I don't want to go there just yet. Hello. All right, so what we're going to do is do some of this on the ventilator itself. We're going to use either the 840 or the Servo I, not using the Draeger, because the Draeger does not have the ability to do pressure triggering. It does, but when you turn off the flow triggering, but it does really weird stuff. So we're going to use a test lung. Obviously, use only one side. We want to go ahead and set the resistance and compliance appropriately, and making sure there's no leak. And you're going to have those graphing sheets. You should have settings that are there. We're going to pull up gently on the test lung to simulate a patient trigger and adjust the triggering sensitivity. And again, you're going to go ahead and try to draw what the ventilator is displaying. And if you want, we can get you a filter, and you can put yourself on the ventilator and feel what it's like to have different levels of trigger present. So we can put you on -20 trigger, and you can see how uncomfortable that truly becomes. All right, so some of you I know had the double triggering when you had that -20 sensitivity. It was very difficult to trigger it, and what you end up doing is you trigger it on, and before the breath is even delivered, you're triggering it again. That's called double triggering, and our patients do exhibit this, so it's not that uncommon. Let me. It's not necessarily, there's inadequate flow for their breath being delivered. They're drawing that much.
You feel like you're hearing hungry then?
Yeah, yeah. And it's all based upon the settings that you end up having. In this case, it was inappropriate sensitivity, but we'll find that you actually can do the same thing with having an inadequate flow setting. We also can have volume triggering, where instead of looking to trigger based upon a certain amount of flow or a certain amount of pressure, when it senses that a certain volume has been depleted, it says, oh, the patient must want a breath. You don't see this often, but there is the Draeger baby log, which is their infant version. And then there's a bizarre ventilator that I don't think I've ever seen clinically. It's called the Venturi, the cardiopulmonary Venturi ventilator. Some non-invasive ventilators have a waveform sensitivity. If you remember back when we were talking about the Vision and the V60, they actually use a a flow tracing to use as a triggering mechanism. There I said it, leave it alone. Impedance. Impedance means it's going to change in the impedance of the chest wall or the abdomen. And a sensor, in this case, is placed somewhere either on the chest wall or on the abdomen. And signals created when the chest or abdomen expands. This is kind of how apnea monitors work, if you've ever placed an apnea monitor on an infant. And that signal can be used to trigger inspiration, and we have it on that CPAP device that we have. So here we have the sensor basically just taped to the abdominal wall. Voila. There used to be a whole lot of ventilators that did it. That's not as common anymore. NAVA. NAVA is a relatively new application. I just want to talk a little bit about it. We know that with conventional ventilation, there's a delay between the time the patient starts the breath and the ventilator kicks on. Now, we may be talking about milliseconds, but that milliseconds can cause some asynchrony with the patient and the ventilator and cause some distress. What we see is basically going from the brain saying, I want a breath, to the diaphragm contracting, to the pressure being built up. That pressure is sensed within the circuit. When it reaches back to the transducer within the ventilator, it goes ahead and, depending upon the sampling interval, generates flow to the proportional solenoid, and then the solenoid has a response time also. So what we're doing is we're basically, there's a delay before the trigger actually starts in conventional ventilator. Same is true when we have flow triggering. There's still going to end up being that delay present. So it doesn't matter if it's pressure triggering or flow triggering, is the bottom line there. So how can the response time be decreased? Well, ventilator manufacturers are pretty much maxed out on what they could end up doing as far as having a faster response time. It's just something inherent within the design of any ventilator. When the ventilator it's looking to see a certain drop in pressure, unless we make that sensitivity so sensitive, it's going to pick it up earlier, but then you run the risk of auto-triggering. So it's a double-edged sword. Maybe move the flow sensor, instead of being inside the ventilator, put it right at the patient. Why? Good idea, bad idea. Flow sensors are basically very sensitive to humidity and secretions. So you defeat the purpose of having it at that point in time. What about if we had the diaphragm be the triggering mechanism? That delayed, as soon as the neural output hits the phrenic nerve, I know it, and the ventilator turns on. Well, how the hell am I going to end up doing that? Well, we have what is called a neurally adjusted ventilatory assist, called NAVA. And basically what it is a specialized esophageal catheter that has electrodes on it, and we're looking for something called EDI, which is basically the diaphragmatic function to use that as the trigger of the ventilator. And it can also be used to cycle it. There is a pocket guide that is available with that URL. Have fun typing that one in. You can just Google NAVA and you'll find it. So what we're doing is we're basically taking that diaphragmatic excitation and using that to go ahead and trigger the ventilator. Here's the NAVA catheter being placed, and there's sensors all along there, and we're having one sensor above the diaphragm, one sensor below the level of the diaphragm, and it can then sense when that muscle is being triggered and use that to trigger the ventilator on. In theory and in practice, it does improve the trigger, and it can also improve the cycling mechanism because it knows when the patient's done with the breath and the diaphragm is being relaxed to trigger it off. And in the process, you get less missed triggers. It picks up on every effort the patient has. You can't quite see this very well. It's only available on one ventilator, and that being the Servo I. And there are some institutions who have converted entirely over to using NAVA as the primary mechanism to trigger. And here we have NAVA, and you can see immediately it's picking up on it and delivering the trigger. So the theory is that in practice you end up having improved patient ventilator trigger sensitivity. There possibly is a reduction in lung damage because of that wanting a breath but not being able to get a breath. It allows for better FRC levels. You use it to optimize PEEP because you know where the diaphragm is as far as overdistension. In theory, helping weaning and extubation decisions. And it's not affected by leaks, not affected by air trapping because I'm not using the conventional methods to trigger it on and off. And it seems to really have found its home in neonatal. I know St. John ended up buying Servo I's simply because they wanted the ability to do NAVA. Okay. And then lastly, there's an operator trigger where anytime you press that manual breath, it's going to go ahead and give us settings that whatever the patient is on. Nurses have gotten into the habit of using this with suctioning, so need to always make sure there are some settings set up there. And again, because I'm manually doing this, the potential is there for air trapping to occur in patients that are airflow limited. I'll let you read that one. Questions? That's it. We'll pick it up next time.
Like if I practice drawing, is there like a picture that I can reference it to, or do I just bring it to you or Amber and you look?
Yeah.
Do you have other case studies or no?
I know there's other.
You can make them up.
Oh, okay.
You are in clinical periodically, right?
No.
You do have patients on ventilators, right?
I haven't had one yet.
Okay. So then you should be able to take their settings, draw it, and look at what you're seeing on the screen and how much it compares with it. Okay. All right. Marco Polo.